I will be talking about a case first. A 5-year-old presented to the ER with complaints of generalized swelling of the body for 3 days. Swelling first started in the face, followed by abdomen and then limbs. There was no history of fever, sore throat, rash, or fast breathing. On examination, there is ANASARCA. Swelling is painless and fitting in nature. Weight of the child is 18 kg. Temperature was 98 degree Fahrenheit. Pulse 110 beats per minute. BP 100 by 60 millimeter at sitting position in left arm. We can find that the blood parameters were normal. Complete blood count. ESR was elevated. In urine routine examination, we could find that albumin was 4 plus. Casts were absent in this case, and WBCs were 3 to 4. Urine culture sensitivity was negative. Urea and creatinine were under normal limits, but cholesterol was elevated. The reference being 200 mg per dl, and albumin was also low. The reference being 3.5 to 5.5 mg per dl. Now, what is edema and what is ANASARCA? So, edema is defined as the accumulation of abnormally excess fluid in interstitial spaces, and ANASARCA is generalized edema of the body tissues with profound subcutaneous swelling and also accumulation of fluid in the serous sacs. ANASARCA is not a disease itself, but it is a symptom of underlying disease. Now, when we are seeing a patient who has presented to us with ANASARCA, so what are the important points we need to ask in history taking? First, we need to ask about the location of the edema, where the edema has started and how it has progressed. The age of onset, because some edema can present congenitally also. The duration of symptoms, whether the edema and ANASARCA is of rapid onset or it is progressing in a chronic rate. Associated complaints that suggest systemic disease or major organ dysfunction, as ANASARCA is a manifestation of any underlying disease, so we need to look for other clinical features which can help in our diagnosis. Past medical history is also important along with family history. Sometimes the patient cannot give the history of generalized swelling, but we need to ask about any history of weight gain or tight fitting clothes and any history of allergies and current medication. Now, how to examine for edema clinically? First, we need to inspect the dependent area of the body for any obvious swelling and check whether it is having signs of inflammation or not.
You see the edema there?
No, actually, first we start from the medial, just above the medial malleolus. We press the area for over 15 seconds.
Should be like that.
Okay. And then after pressing for 15 seconds, we move our finger and look for any obvious indentation. If the thumb impression is causing any indentation, then that edema is said to be fitting. And then gradually, if we found fitting edema over here, then we gradually progress upwards. So in ambulatory patients, we find edema, fitting edema in the legs. Other sites where we can look for edema is a sacral edema in non-ambulatory patients. In face, we can find periorbital puffiness. Here, there is ascites, which we can see by fullness of the flanks and also the genitals, labial edema in this case. Also, ANASARCA can also be associated with bilateral pleural effusion. And we can also find evidences of fluid accumulation in serous cavities like bilateral pleural effusion, as it is evident in this case, which can also be checked by decreased breath sounds in auscultation and dullness of percussion. Ascites can also be checked by fluid cell and shifting dullness. And also, we also need to check for localized edema, because if edema is localized to the face, then child should also be carefully evaluated for concurrent airway involvement, because many times allergic reactions precipitate with laryngospasm. Now, pathophysiology of edema and mechanisms which can cause edema. So mainly we have these three things: increased hydrostatic pressure in the capillary, which can move the fluid from intravascular space to the interstitium, and also reduced plasma oncotic pressure, which will drive the fluid outside, along with sodium retention. Now, ANASARCA can have causes like cardiac cause, hepatic cause, renal cause, some causes related to nutritional, enteropathic cause, and allergic cause. So one by one, I will approach ANASARCA. How to approach ANASARCA when we are suspecting that there might be cardiac origin. That can come in heart failure and pulmonary edema. So basically, what happens in heart failure? There are two things happening simultaneously. One part, there is reduced cardiac output, and due to reduced cardiac output and venous stasis is causing increased hydrostatic pressure, which is again causing edema. And reduced cardiac output is causing activation of RAS pathway, which is causing increased ADH production and aldosterone secretion, which is causing sodium and water retention. So that causes edema, which progresses to ANASARCA. What will look for the symptoms in the child? It can have heart failure, can have variety of presentation. In infants, tachypnea and diaphoresis during feeds and easy fatigability along with irritability is more common. In young children, we can find jugular venous distension, enlarged tender liver along with respiratory distress and ANASARCA. Now, on examination, the signs which we can find is tachycardia, poor perfusion, gallop rhythm, tachypnea, respiratory distress, and in case of pulmonary edema, we can find basal crepitations. Along with that, hepatomegaly and peripheral edema can be seen. Now, if we are suspecting ANASARCA in a case and we are thinking about liver disease, then first we need to know about the pathogenesis. In liver disease, there is decreased albumin synthesis, and hypoalbuminemia is causing decreased plasma oncotic pressure. So that can lead to transudation of fluids into the interstitium. Moreover, hepatic venous outflow obstruction can cause and portal hypertension can cause expansion of splanchnic circulation. So there will be decreased effective arterial blood volume causing renal hypoperfusion. Renal hypoperfusion will again stimulate the RAS pathway, which will cause sodium and water retention, and it will result in ANASARCA. The patient will come with symptoms of jaundice, change in mental status, history of easy bruising, vomiting, fever, and pruritus. History of anorexia can also be there. When we are examining such patients, we will need to look for any asterixis, any signs of altered mental status. We can also see the skin for any spider angioma or palmar edema or purpura. Also, in cases of portal hypertension, we can find superficial abdominal veins in caput medusae pattern. Anorexia, dyspepsia, nausea, vomiting, and change in bowel habits can also be present in the history. In older children, there can be testicular atrophy, amenorrhea, and gynecomastia, along with ANASARCA. Now, while talk about ANASARCA of renal origin. So what the pathogenesis, basically what happens in cases of nephrotic syndrome or any pathology related to the kidney, there is damage to the glomerulus, and glomerular damage causes plasma proteins to escape into the urine, which causes hyperalbuminuria. Now this hyperalbuminuria is called decreased plasma oncotic pressure, and it will cause the fluid to move out into interstitial spaces. Moreover, decreased circulating volume will again stimulate the RAS pathway, which will again cause sodium and water retention, and that will lead to ANASARCA. Now, when we are thinking about ANASARCA of renal origin, we need to consider three main things. One is nephrotic syndrome, one is nephritic syndrome, and one is chronic kidney disease. So, the main features of nephrotic syndrome are edema, which begins in the face, and then proteinuria along with hyperlipidemia. Nephrotic syndrome generally can present to us as respiratory distress, maybe due to the bilateral pleural effusion, and also due to repeated attacks of vomiting. Nephritic syndrome can present to us with history of sore throat or any skin lesion 2 to 3 weeks back, and it is characterized by oliguria, hematuria, and hypertension on examination. Now, a short table showing differences between nephrotic and nephritic syndrome. We just need to remember that in nephrotic syndrome, the edema is insidious in nature and it is very much prominent. Blood pressure is normal, but proteinuria is very high and serum albumin is low. In nephritic syndrome, on the other hand, blood pressure is raised, jugular venous pressure is raised, Proteinuria is not that significant, but hematuria is significant, and we have history of cola-colored urine. And to differentiate between acute kidney injury and chronic kidney injury, obviously, acute kidney injury will have a short duration and history of acute illness, and the child can come with hypotension, fluid overload, and acidosis. In chronic kidney disease, there is better toleration of biochemical abnormalities, and the child will come with anemia, cachexia, and gray discoloration of skin. The hemoglobin may be normal or low in acute kidney injury, but due to erythropoietin deficiency, chronic normocytic anemia will be present in patients of CKD. In acute kidney injury, creatinine will have rapidly increasing value, but in chronic kidney disease, there will be history indicating derangements and stable serial measurements will be there. Also, there is role of USG in differentiating between AKI and chronic kidney disease. In renal ultrasound can often be normal in AKI, but in chronic kidney disease, the scars must be present from reflux neuropathy and kidney can be shrunken. In some cases, there are large kidneys, exceptions like diabetes, amyloidosis, polycystic kidney disease, and chronic hydronephrosis. Also, renal ultrasound is most of the times normal in AKI, but sometimes in hydronephrosis, acute hydronephrosis, the kidney is enlarged in ultrasound. Now, ANASARCA of nutritional origin. We'll think about kwashiorkor, which is a type of malnutrition in which there is adequate calorie intake, but there is low protein intake. Now, adequate calorie intake stimulates the insulin levels, which is an anabolic hormone. Due to the anabolic property of insulin, there is increased synthesis of amino acids, but essential amino acids are not available. So, albumin is not synthesized, and hypoalbuminemia causes edema, and failure to synthesize beta protein causes fatty liver, which later progresses to liver dysfunction. Now, symptoms and signs in a patient of kwashiorkor. So, from top to bottom, symptoms will be brownish hair, mental retardation, anemia, loss of appetite, stunted growth, underweight child, along with dark and scaly skin, protruded belly, and swollen legs. While examining the signs, we can see the flag sign in here because there are alternating periods of proper undernutrition and malnutrition. During the time of undernutrition, the hair growth is scanty, and then the hair growth is normal. So that causes flag sign in hair, apathy, irritability, muscle wasting, anemia, villus atrophy of small intestine, which can cause diarrhea, depigmentation of skin. In cases of kwashiorkor, the skin is fragile, and that leads to flaky pain dermatosis. We can find all this along with ANASARCA. There is one more nutritional cause of protein called protein losing enteropathy, in which diseases such as ulcerative colitis or Crohn's disease or Meniere's disease, this causes intestinal leakage of plasma proteins resulting from inflammatory exudation and increased mucosal permeability, which causes rapid loss of protein from the gut. And we suspect protein losing enteropathy in patients where there is hypoalbuminemia, but the urine albumin levels are normal. Patients usually present with peripheral edema. Rarely, patients may present with gradually progressive dyspnea or painless abdominal distension due to symptomatic pleural effusion or ascites. One more clue which we get in cases of protein losing enteropathy is that there is ascites first and ANASARCA later. Gastrointestinal symptoms of diarrhea, steatorrhea, abdominal pain, bloating, or flatulence may be present in patient with underlying small bowel or colonic disease. Now, ANASARCA in case of allergy. So that is why history taking is important, where we need to ask about any skin contact to poison plants, animal, pollen, any history of bee sting, and medications, because some medications like the ACE inhibitors can cause elevation of bradykinin levels, which can lead to ANASARCA. Also, inhalation of any pollen, dust allergy can cause ANASARCA. Now, anaphylaxis we need to know because that is a medical emergency. The patient can come with lightheadedness, loss of consciousness, confusion, headache, and anxiety, which can be associated with swelling of lips, tongue, or throat. We also need to ask about any history of shortness of breath, and patient can come with hoarseness of voice. There can be crampy abdominal pain, diarrhea, and vomiting, along with itchiness and flushing of the skin. Now, angioedema can be differentiated from generalized edema, which is angioedema is actually non-pitting type, and that can be differentiated from edema of pit, that can be differentiated from ANASARCA. ANASARCA has the following differences from angioedema. Angioedema is actually more rapid in onset. It is asymmetric in distribution, and distribution is not always there in dependent areas. There is prominent involvement of lips, larynx, and bowel, and there can be an association with anaphylaxis. Now, some other causes which I will mention is the in patients of Turner syndrome and Noonan syndrome, there can be congenital edema of hands and feet, and also a neonate can present with ANASARCA in cases of hemolytic disease of the newborn and hydrops fetalis. Hydrops fetalis was for immune causes like ABO and RH compatibility, and non-immune causes also like torch infection and any cardiac causes, congenital heart defects, and any lung causes which can present in ANASARCA in a newborn. One more cause of non-pitting edema is mixed edema, where uncompensated hypothyroidism can cause non-pitting edema along with bradycardia, hypothermia, altered sensorium, and constipation. Enlarged thyroid gland may be present. Now, by history and by examination, we will be able to make out the direction in which we want to proceed and the cause of ANASARCA. For that, we will give relevant investigations. In routinely, we give complete blood count, urea creatinine, LFT, and urine analysis for every patient. If we are suspecting liver disease and liver origin, then we will give liver function test, PT, APTT, INR, and serological test for hepatitis B and C. If we are suspecting cardiac origin, then we'll give chest X-ray, ECG, echocardiography, and cardiac enzyme. Like in heart failure, pro-BNP and anti-pro-BNP can be elevated. Kidney, if we are suspecting nephrotic syndrome or nephritic syndrome, their urine analysis, urea creatinine levels, serum electrolytes, and serum albumin level will give us important clues. In nutritional anemia, we'll see for complete blood count, blood glucose level, serum electrolytes, and plasma protein level. In allergic causes, although many cases are an emergency, but we can check for skin allergy test and serum IG levels. Treatment is not actually treatment is to treat the underlying cause, but general supportive care can be done in which there is restricting of fluid and sodium intake. Judicious use of diuretics is important because diuretics can lead to depletion of the intravascular volume, and that can precipitate more heart failure and AKI. So that should be kept in mind. And infusion of albumin, if required, it will only be beneficial in cases where the edema and ANASARCA is developing due to decreased plasma oncotic pressure. Now, I will summarize the whole thing. If we find the edema which is local, yes or no. Now we were dealing with ANASARCA, so the edema is not localized. We'll check for any evidence of cardiac disease. Then, if yes, then congestive heart failure and pericardial effusion can be the cause. If no, then we'll check the urine report. If the urine report is suggesting of some positive finding, then we'll think of renal disease. Otherwise, we'll check LFT and electrolytes and albumin levels. If it is suggestive of positive findings, then we can see of hepatic disease, GI disease, drug toxicity, and salt intake. If that is also negative, then we can think of allergic reaction, vasculitis system, premenstrual syndrome. And then we'll further progress and we can differentiate between vasculitis and premenstrual syndrome. Also, this is a short chart in which how investigations can lead to diagnosis of ANASARCA. Like congestive heart failure, we will give ECG, X-ray, echo. In nephrotic syndrome, we'll check for urine analysis, blood urea nitrogen, creatinine, albumin, cholesterol. In liver disease, we'll check for liver function tests, electrolytes, and viral markers. We can also do ultrasound abdomen, and GI endoscopy will be required if a patient of ANASARCA and suspected liver disease present with hematemesis. Also, in symptoms of malnutrition, we can check for albumin, complete blood count, calcium, and we can examine stool for ova and cyst. Thank you.
Why did you choose this subject? Should be a case case. Usual case, unusual case. This is not undergraduate life. Very much undergraduate life. That you should be having a case, and then on the basis of that, you differentiate between. I mean, don't copy paste it from the. It's extensive, but most of you know that EDEMA can be like liver or kidney or heart and nutrition, and then accordingly you justify right. I mean, you chose the subject. No, you should give them a case based. No, you should give them a case based. Give them a case and how you approach that patient. Approach to ANASARCA is too extensive, and like if I approach newborn baby or preterm, the most common cause of edema that we see has been mixed. One is the edema of maturity and then fluid overload. So these are the two important causes which we are.
Hydrocephalus, hydrocephalus.
Discussion was very extensive, but I didn't even talking about ANASARCA, it talk only about ANASARCA. Don't go into individual EDEMA topics. Not extensive. You don't need approach to EDEMA also. Approach to ANASARCA is a subsection of it.
Did I look at a case to which the
Now, if we are in a postgraduate stage, we can have it in the following sort of headings. First is what you are going to present now, what is the objective of your presentation, if the cases, what you summarize, give the summary, and then again when you give the cases, don't give it out everything. And the last bit you give what is the diagnosis. Like
I want to see because it's going into the show. And if anyone says, oh, so, yeah, I mean, primitive
Monday evening.
Primitive type of presentation. It has covered extensively, but presentation should have a proper slide also. The slides were not correct. So it's a copy paste. Because it's a very small font, so it is not visible also. It's not visible also. People who are seeing in mobile, if at all. If at all, they will not be able to. Because zero views go away because your presentations are not good, it will be zero.
Presentation. These are all topics from the exam long question. So when you present in no complex sense, always outside the algorithm where I can go through the like if I follow the algorithm, I can read the major diagnosis. More
এখন our senior के बाद ही acting आने के लिए देखते हैं
Hmm.
It's a learning process.